Good afternoon, everyone. Welcome to our LHS Professional Development Core Retreat. It's very nice to see so many people here in person, and we have over 300 people online. So really appreciate it. Part of it is due to the fact that we have an outstanding speaker, and we look forward to his lecture. Our speaker is Dr. Thomas LaVeist. He's the Dean and the Weatherhead Presidential Chair in Health Equity at Tulane University School of Public Health and Tropical Medicine. He is very well known for his work in medical sociology, a topic that many of us don't know much about. He has a PhD in that from the University of Michigan and has done a fellowship in gerontology and public health policy, also at the University of Michigan. And he's worked on several areas of research involving social and behavioral factors that predict the timing of various health outcomes, how these factors explain race differences in health outcomes, and the impact of social policy on health and quality of life of African Americans. He's done both quantitative and qualitative analysis, and he's received numerous awards from various bodies, including the National Academy of Medicine. He's received the Innovation Award from the NIH and the Knowledge Award from the USA Department of Health. And he's produced a documentary series about racial inequality in health. So welcome, Dr. LaVeist. He's going to tell us about racial inequities in health, what we know and what we think we know. So let me make sure this microphone works.
Well, good afternoon. Okay, good afternoon. But I know we're not church, but if I call, you do what? Okay, so you know what you're supposed to do, right? So good afternoon. Come on, give me some energy. Thank you. Let me just turn this off. So I was asked to come in and talk about the issue of health equity or health disparities, health inequities, all related terms. And at this point, I would imagine that everyone here is pretty familiar with the issue of health inequities, what we're talking about. But I want to ask you a little different question. And the question, go ahead, first slide, please. Can you imagine this society without racial inequities in health? Can you imagine that? What would have to happen? What would have to change? Now, unless your brains don't operate like most other people's brains, some thoughts into your mind, right? But, what would need to happen? And what undergirds that question is, why do they exist? Why do we have racial inequities in health that are persistent across all disease categories, infectious disease, chronic disease, injuries, accidents, you name it. You name a way people can die, and you've got a disparity. Okay. Now, many of you probably, I would imagine, can't imagine this society without having these inequities, because they've been with us for as long as we've been able to measure them. But I can imagine that. And that's because I can remember the time when I didn't know that we had racial inequalities. This was back when I was a graduate student. I was working on my dissertation, and for anyone here who's written a dissertation, you can, I'm sure, relate to that moment when the tedium, the isolation, and the boredom gets to you, and you don't think you are about to lose your mind. If you're not nodding your head, you didn't write a dissertation. That's a requirement of the process. Well, I was having one of those days, and I thought, okay, let me do something else, anything else. Right? So I decided I'm going to take a walk. I'm going to take a walk downtown Ann Arbor, Michigan. And if you've been to Ann Arbor, Michigan, you know, it's a pretty short walk. And I see a bookstore, used bookstore, and I say, this is an honorable way to procrastinate with books. Right? So I go to the bookstore, I'm looking for something to read. Now, the standard is any book that doesn't have a bibliography. That was it. I'm going to open to read anything. So I go to the used book section, or the clearance section in the used bookstore, and I come across this book. Next slide. A Night to Remember. This is a book about the Taipan, which probably says something more about my mental state, but I would be going. As I was thumbing through this book, and I come across this page where they're talking about survivors on the Titanic. Now, this was probably 10 or 15 years before the film about the Titanic happened, so I know how that happened, but it didn't occur to me that there were survivors. I just thought the narrative was, should his iceberg sinks, everyone dies. What's the book? What could the book possibly be about? So I started looking, and talking about who survived. So I started calculating the death rates. Now, this really tells you what my mental state was. I am standing in the clearance section of the used bookstore, calculating death rates rather than writing my dissertation. Next slide. And these are the rates. I'm objective now. The rates show that the class of ticking was predictive of the likelihood of survival, which at the time I didn't know how that happened. If you care about how it happened, I'll talk about that after the lecture if you don't know. So when you look at the magnitude of this difference here, this is fascinating, right? And this occurs to me that this is a perfect illustration of the U.S. healthcare system. Create expensive systems, weeding out unequal treatment, destined to hit an iceberg. And when that happens, it's going to be the results I predict will look something like this. Now, next slide. So when you look at the magnitude of what we have here, it was an issue of scarcity. There was only enough vital space to accommodate.
Recording in progress.
Alexa. Only 53% of the people on board. And so that means on that evening of April 15th at 9:11 p.m. in the North Atlantic, space on a lifeboat is a scarce resource. And when it comes to scarce resources, who you are determines who gets access to those resources. Thus the outcome song. Now you might think that this couldn't happen today. More than 100 years ago, right? Next slide. This is the U.S. airline that landed on the Hudson River outside of New York, in New York back in 2009. And I did not Photoshop this except to write in coach class and first class. And as you notice, the first class passengers are in lifeboats. The coach class passengers stand on the wing. So now, how is this possible? Now, I am where the rubber meets the road, I'm a health policy professor, so I can't help myself. I have to take this moment to talk a little bit about health policy. Where the rubber meets the road, this is a photograph about policy, action, and inaction. Right? How is this photograph possible? It's possible. Now, how could we have prevented this photograph from happening? Most people think that the way that we deal with these issues is through legislation. We get Congress to pass a law, we get the city council to pass the law, we get the state legislature to pass the law, and then the problem is solved, which is, of course, not at all the way it all works. Legislation, of course, could have been a solution. Congress could have passed a law that said if you're going to operate an airline in the United States airspace, you have to have enough lifeboats space for everyone on board. So legislation certainly could be a solution. However, the Department of Transportation could simply pass a regulation that says you can't operate without having enough lifeboats. But it doesn't stop there. U.S. Air could have said, as a matter of policy, we will not purchase or lease an airliner that doesn't have enough lifeboat space. And the manufacturer could have said, we're not going to build an airline out of lifeboat space. So what's my point? The point is that the health policies that impact the health of the population happen in many different places. And as advocates for the public health, we need to be sophisticated enough to understand where policy happens. Right? There's no city council that is deciding that this neighborhood will be a food desert and this neighborhood will not. It's typically corporate policy, right? And zoning policy that's making the determination. So that's the end of my soapbox. I'll be on the soapbox and get back to the lecture. So understand policy is complicated, happens in many places. We need to be effective actors in all of those places if we're going to improve and protect the health of the population. Next slide. So this slide is the kind of my bottom line slide I like to use to describe to people who maybe not be initiated to the issue of health inequality. And I like this one because it's very simple and it's very easy to see. This is a age-adjusted mortality rates, and what it clearly shows that we've got a persistent problem of disparities. This chart is for 2018. This chart could have been for 1998, 78, 68, 58, 38. As far back as we can go with good quality data, the chart looks like this. And the question is, why? Next slide. Next slide. So, when I talk to people about this issue, and maybe even some of you in the room, when I ask, can you imagine the society about disparities, some ideas may pop into your head about why it exists. These are the three most common explanations that I get. I have characterized them here, not as explanations, but as myths. And I'm going to talk about why these are all myths and not explanations for the disparities, because none of these three reasons are the reason why the racial disparities exist. They are factors, these are issues. I'm not saying that these aren't important things, that socioeconomic status is not an important issue. Access to healthcare is not an important issue. I am saying that there are not biological differences between race groups that justify that, but I'm saying that these are not the reasons for the disparities. And I'm going to go through each of these reasons and talk about why they are not, and why some of what we think we know about racial disparities is incorrect. And then I'll talk a little bit about methodological issues in the study, the research that we do in racial disparities in health, and then talk about what I think is driving the disparities. So first, access to healthcare. Next slide. So this is a chart from a study that was conducted by some guy named Thomas some years back. This was a study that we did in Baltimore. This is the 3 hospitals in Baltimore. And this was the pre-electronic medical record days, or at least what medical records we had at that time that were digital, were still using DOS. And there are a couple of us here that look like you're old enough to remember DOS. I certainly do. This operating system, right? So we went into the basement of these 3 hospitals and did a medical record abstraction of over 10,000 records, paper records. And we were looking to determine among patients that had been seen at these hospitals and who had a DRG that would suggest that they may have been a candidate for coronary angiography. We were looking to determine what was the rate of referral for coronary angiography. So what you see here is the results of that study, and this is the subset of patients that had insurance. So these were insured patients who were being seen at a hospital that had a cath lab. So the hospital had the ability to provide the service. We abstracted the medical record using American College of Cardiology, the American College Association guidelines for referral for coronary angiography. And 100% of the patients represented on this chart should have been referred. So in terms of medical appropriateness, both of these bars should get 100%. But we see 2 things here. First is that the bar representing white patients is not at 100% either, right? So this is a problem of quality. So we've got a quality issue, but we've also got a disparity in quality issue because we see that the rates are different, right? The black rate is even lower. Next chart, next slide. This is another study that I like to use because I think it follows my study nicely. This is based in a VA hospital in Pittsburgh. So this is for revascularization, but here once again, these are all VA patients being seen at the same VA hospital by the same set of physicians. They did a medical record abstraction here as well, and once again, 100% of the patients on this chart should have been referred, but we see the same pattern. Only about 50% of the white patients were referred, so we've got a quality problem. And of course, only about 26, 27% of the black patients. So we've got this disparity in quality. So here we have 2 examples where we have universal access to care because we've excluded people that did not have access. And even here, where people had access to care, they have insurance that would have paid for the procedure. They were medically appropriate. They were being seen at a facility that had the ability to provide the service. So whatever barriers they had to overcome, they overcame those barriers and they got seen. And we see there's still a disparity. So simply equalizing access to care will not address the racial disparities problem in and of itself. Next one. Next. The next one is this idea of genetic differences. And this is a really interesting one to me, because in order for genetic differences by race to be the reason for the racial disparities, there would have to be some gene that is producing heart disease, cancer, and stroke, and diabetes, and injuries, and gunshots, and HIV, and automobile accidents. And obviously, there is no gene that does all of that. And also only belongs to one race, right? So that is utterly ridiculous, right? But this idea of race and genetics does still keep the child thinking in much more subtle ways. Next chart. So how many of you here are familiar with this drug, Fido? Or let me ask you this, how many are not familiar with Fido? Okay, so I'll have to tell enough of the Fido. So for those of you that know about Fido, give me the abbreviated Reader's Digest story that I tell. But Fido is a drug to treat congestive heart failure, well, cardiovascular disease more broadly. This is a drug that is very effective. From the research that has been done on it certainly suggests it's an effective drug. But it is interesting, although not surprising to me, that everyone here is not familiar with this drug, which should be a tool in your arsenal. Fido was developed, so back in the 1970s, early 80s, new drugs were coming out onto the market for cardiovascular disease. Drugs that are commonplace now, you know, the whole class of calcium channel blockers, beta blockers, and they were, you know, believed to be a significant improvement over diuretics, which were at the time state of the art. And some physicians discovered that if you added these two very inexpensive generic to the calcium channel blockers, the beta blockers, that's isosulfide dinitrate or hydrolysine, that combination was very effective. So they got the idea of, well, let's do a clinical trial to document that this combination therapy is as effective as we can get it to. So they do a trial, and the trial is so successful that they have to stop the trial because it's clear this combination is very effective. They published the article in the Literature on Medicine, and this is a wonderful story because we now have this new therapy, highly effective therapy for patients with this debilitating disease. Congestive heart failure, about 500,000 cases per year, about 5-year prognosis, and of course very expensive because we spent a lot of those last 5 years in mountain race. So this is great. This is a new tool that we now have. And it would have been a great story if it ended there, but it didn't end there. They then said, okay, what if we put these two generic drugs together into one pill? We get a patent for that, right? It would be an economic windfall that we would get from it. So they do this, right? And they try to come to market with this new medication. And FDA says, I'm sorry, you can't go to market because the trial that you did that was published in the Journal of Medicine didn't meet all of FDA standards. So you have to do a new trial. So now imagine that. If you got to do a new trial, by the time you're able to organize a new trial, it would be on patent and you would lose the economic windfall. So what do? You've got this valuable thing, but you can't really make the most use of it. So they decided to go back to the original data and they do a little data mining. And they discover that this combination therapy is more effective in Black patients. Okay, now I said it that way intentionally. Have you heard that terminology before? This drug more effective in Black patients. That drug more effective in white patients. Even today, you go to Association of Black Cardiologists and ask most of them, some of them, my good friends, they will tell you Black patients should get diuretics, white patients should get calcium channel blockers or beta blockers. Although, and we could have this debate after my lecture, the science does not support that. The all have studies that not support that if you need the actual data. I'll come back to that because we're sure there's so many of them going to have that conversation. So this idea that the drug is more effective in Black patients, now they came to that conclusion because when they segmented the sample by race, they saw a bigger effect size in black patient population than the white patient population. So let's talk about what that means in reality. So I'm going to give you an example. These are not the statistics from their study. But let's say we had 200 patients, 100 white patients, 100 black patients. They all have the same diagnosis, and we've got this medication that treats the condition that they have, right? Or at least we think it does. And we do an experiment. We give all 200 of these patients the medication. And here are the results we get. 75% of the black patients benefit from the medication, and 65% of the white patients benefit from the medication. Are you with me? Okay. Is the drug more effective for black patients? Who says it is? Okay. Who says it's not? How many of you are too afraid to answer the question? It's not a trick question. Well, that was the result. That's what they found. They found a higher percentage of black patients benefited than white patients, and they concluded that the drug was more effective in black patients. So the answer is, of course, a higher effect size in the black population does not mean that it's more effective in black patients. Now, it was effective for more black patients. It was a higher percentage of black patients that benefited. But if you were part of the 75% of black patients that benefited, you benefited. If you were part of the 65% of white patients that benefited, you benefited. You didn't benefit more or less. You either benefited from it or you didn't benefit from it. Right? But they went back and got another patent. This, by the way, was 2 years after the Human Genome Project had already demonstrated that there are no differences in race at the genomic level. They go back and they get a patent now for use of this drug in only black patients. The first time in the United States this happened, 2005, not 1905, 2005. So the question I have is, to whom do you prescribe Bidil? Next slide. Do you prescribe Bidil to this African-American gentleman who has 2 grandparents from Ireland, 2 grandparents from Jamaica, and was born in the Bronx, New York? Paul Powell. Next slide. Do we prescribe it to this African-American gentleman who has 2 grandparents from Kenya, 2 white American grandparents, and is born in Hawaii, which is part of the United States? Still confused about that. President Obama. Next slide. Do we prescribe it to this African-American gentleman who has 1 Thai grandparent? He's got 1 Chinese grandparent who also has Thai ancestry. He's also got a white American grandparent who has Native American ancestry and a black American grandparent who also has Native American ancestry. From whom did Tiger Woods inherit his Bidil receptor? And how do you know? By simply asking his race at intake. Next slide. By the way, what about this guy? He looks like a black guy to me. Should I prescribe it to BJ Singh, who is from Fiji? He's not African American at all. Now, hopefully, BJ Singh will never need Bidil, but if ever he did, I would hope that it would be available to him, because what we know about the drug is that it's an effective drug. But this is the way that this idea of race and genetics creeps into the minds of otherwise thoughtful and intelligent people. They got an approval from the FDA to bring this drug to market as a black drug, the panacea for racial disparities in health. Also, that if they were fully successful, white patients would not be able to get Bidil, right? Only if they were using it off-label. Next slide. So, this explanation or myth is the one that I find the most fascinating one, because it is the easiest one to dispel. That it's not really race, it's really poverty or economic status. To which I would always say, well, even if that was true, what is the relevance of that? People are living sicker and dying younger than they should. Whether it's because they're race or their social class, it's a problem, right? However, that is not true. So here are a couple of slides that I can quickly show this is not true. This is some slides I put together from data from the National Health Inequity Survey from, I think, 2013, which just happened to be the version that had on my hard drive. So it's really that simplistic. It's so easy to prove. If you look across every disease category, just a few examples. Don't flip through so many slides. It doesn't matter much what the outcome is. The pattern is the same. Increasing socioeconomic status reduces your risk, and disparities exist at all levels of socioeconomic status, whether we're talking about income or education. There was one exception, which is hypertension. Did we pass that already? I think it's the next one. Try it next. Okay, keep it going. There we go. Yeah, stop. Hypertension, the only exception where you actually find for African Americans, the risk of hypertension increases with income. This is for people who are very high income, $175,000 or more. Why would this be accepted? Anybody have any thoughts about why this one example that I can think of, I've seen in my entire career, never seen another example of any condition that increases with socioeconomic status. But why would the highest income African Americans have a higher risk than the lower income African Americans? Oh, they can afford to buy bad food. Oh, so high income African Americans are more likely to make bad food choices than high income and lower. But the weights are not increasing as their risk is decreasing. Diagnosis. Oh, that's interesting. That's an interesting answer. I don't believe that's accounting for that, but that's an interesting new one I hadn't heard before.
I would say stress, or not that most you don't have stress, but different stresses.
I think that is the answer. I think that as you become an African American in this income category, is more likely to be the only Black guy in the room most of the time. The stress and pressure of that, and what you have to do to become an African American making that kind of income. Think about where the judge who is now being considered for the Supreme Court. Think about how much stress he has had to endure, how resilient she would have to been in order to be where she is at this point. I think this is the result of that journey. All right, next slide. So, message to the researchers. Here we go. This is my favorite slide. So, now when I show the slide on socioeconomic status and race, it pops into people's heads often, and I see I have a few economists in the room, so I know the economists probably like this. Oh, well, we have multivariate modeling and we deal with these kinds of issues and we can account for that sort of thing. So here's my response to that. So I'm going to do a quick data analysis for you. The example will come from the National Health Inequity Survey. Next slide. We're going to look at all adults over age 40, which is the sample size of about 33,000 cases. About 4,400 African Americans in the data set. Next. And we're going to look at income in three categories: less than 20,000, 20 to 75,000, 175,000. You see the sample sizes of each of those categories. And the dependent variable will be ADL, activities of daily living, which is a measure of physical function, right? So this is going to be a very simplistic analysis to look at race disparities in activities of living and having one ADL limitation. So I'm saying the bar pretty low here, just one ADL. And can we do that analysis adjusting for income in a sample of 33,000 cases? Okay. Next slide. So the first thing we do, this is the biostats 101. We look at the bivariate relationship between race and ADL limitation. And we've done that using regression, logistic regression. Odds ratio of 1.46. indicating African Americans have 46% greater odds of having one ADL limitation compared to whites. Confidence interval tells us that this is significant, and so far, this is exactly what we would expect to find, right? Next slide. So next we look at income, and here we see that the odds of having an ADL limitation is decreasing as income increases. Again, confidence interval is telling us that this is a significant effect. So again, this is exactly what we would expect to find. So what's next? We now progress the biostat 102. So now we're going to put race and income together in a model to see what happens. Next slide. So here we've done that, and we see a couple of interesting things. Next slide. Oh, I'm sorry, go back. Yeah, so a couple of interesting things. First, look at what happens to the odds ratio for income. The pattern remains the same, right? As income increases, the odds of ADL limitation is increasing. Confidence interval is again telling us that the income effect is insignificant. But what happens to the race effect? Race effect, confidence interval is telling us that it's not significant. So what do we do next? So this is not a rhetorical question. This is an actual question. What's the next step? Okay. You publish the article, right? Publish the article, right? And you get a better praise, and all is right with the world, except you have now added false information to the research literature because you didn't take this next step. Next slide. Of simply arraying the data by race and income and looking within each cell to see exactly what you have. And if you do that, you find a couple of interesting things. Next slide. First, in the income category of $20,000 income or less, you actually do have a significant race effect that was masked by that multiple regression. Now, it's not a huge effect. It's not necessarily substantially important, but it certainly is statistically significant, and it was masked by the multivariate model. The second thing we find, next, is in the income category of $75,000 or more, African American, that rate is only being calculated on the basis of 8 events. So in our data set of 33,000 people, there were only 8 African Americans with incomes over $75,000 who had at least one ADL limitation, one limitation. Which I can, if you're not familiar with ADL, that was testing you, that is not a very disabled person, right? How many analyses of race disparities have you seen using much more complex analysis than this? A much smaller sample size. Now, before anyone gets too embarrassed here, if you go to PubMed and you punch up my name, you will find that I've committed some of the very sins that I'm talking about here today. So it's not a matter of that he who was without sin cast the first stone, but rather this is repent and go forward and sin no more. So if you find that I've done this recently, you can come after me. Most of the analysis that we have done on race disparities have been far more complex than this analysis. And I don't know about you, but every statistical technique that I know that is more complicated requires a larger sample size, not a smaller sample size. So how many times have we made conclusions on the basis of 8 events and extrapolating that rate to the entire country, right? Which is literally what the health community survey is for. Okay, let's sit with that for a moment. Next slide. But it's okay. Next slide. Next slide. So what is race? What is race? Where does that concept come from? The concept of race evolved out of explorers and naturalists in the 1600s. After Europeans discovered that there were other parts of the planet and that there were actual people living on other parts of the planet, they began exploring the planet. And they also discovered that there were different animals that didn't exist in Europe. And they came up with schemes for classifying these different species. And the idea was that humans could be classified similar to as we do with adults. Next slide. And these classification systems basically were based on the visual assessment of phenotypic differences of people living in different continents. And not only were they categorized they were not just categorized in a neutral way, but they were categorized in a hierarchical way. The idea that there were different categories or species of mankind, and that they had different values and different levels of intelligence, different levels of industriousness, different levels of all positive characteristics, and they could be arrayed in a hierarchy. This is one of the more popular hierarchies at the time. Next slide. These naturalists, beginning in the 1600s, came up with this idea that there were 5 classic categories of mankind, literally mankind, the terminology they used, and it was these 5 categories was based on skin color. And these categories were Caucasian or white, Mongolian or yellow, Malayan or brown, and Negro or black, and American or red. Next slide. And here they are. Next. So in 1977, the US government develops for the first time an official definition of race to be used in data collection with OMB Directive 15. And they here they take those 5 categories and say, these are the 5 categories that you are to use in all data collection for federal data. Next. But there's an even longer history of the use of race in the United States. So for these next 3 slides, I'm going to show you the way that race is measured on every census ever taken in the United States from 1790 to 2020. So in 1790, race was free white males, free white females, all other free persons, and slaves. Right? Then when we moved into 1830, we start getting, 1820, free colored persons get a separate category other than slaves. 1850, mulatto gets added, mulatto meaning one black parent, one white parent. 1860, Indian is added. 1880, now we're adding nationalities, so Chinese gets added as a nationality. By 1890, quadroon and octroon, meaning 1/4 black, 1/8 black. So we've started to parse the mulatto category. And of course, now we've added Japan, another country that's added a nationality, not a racial ethnic group. Next. Moving into the 20th century, we start getting religions added here. So in 1920, a Hindu gets added as a race, not a religion. Filipino gets added, black becomes Negro. Second half of the 20th century. Now we start to need more lines to get the categories in. So the point I'm making here is that if race is this measure of some aspect of biology that's meaningful to the work that we do, then how is it possible that the Census Bureau can simply make decisions about how we change those categories? Decisions that are made, policy decisions, political decisions, that are responding to social understanding about what these categories are, what they mean. There's no biological measurement involved in any of this. Yet we in the health sciences and taking the same variables, measured the same way, using the same methods that Census Bureau does, and we ascribe biological meaning to it. Next. So if it's not genetics, if it's not healthcare, if it's not socioeconomic status that's driving these disparities, then what is it? Next. I say it's the fact that we live in the country together, but we experience this country in very different ways on the basis of how we are categorizing this country. Next. So this is a map that was produced at the University of Virginia This is based on the 2010 census. They have not updated this yet, but this map shows every American 2010 census. And they put a dot on the map representing every American. So over 300 million dots. And the dots are color coded based on race. So that you can see geographically where people live. Blue dots represent white Americans, green dots are black Americans, Asians are represented by red dots, Hispanics by orange dots. Let's go to the next map so we can see this little more clearly. So maybe we should dim the lights a bit. That would help, I think. But this is Washington, D.C. And I've zoomed in on Washington here. And if you notice here in Washington, this, for those of you who know the Washington, D.C. area, you know that this is not a very big geographic area we're talking about here. And you notice that clearly the green dots are to the east of the city, which is Maryland, Prince George's County, Montgomery County, but mostly Prince George's County. To the west of the city, you see mostly the blue dots. Next slide. Robert Johnson Foundation illustrated the same concept this way using the DC Metro. And what it shows here that if you are at the central DC Metro Central stop in the city, life expectancy is 72 years old. And depending upon which metro line you get on to go home, we can predict life expectancy. So if you get on the green line, you go into Prince George's County, which is where predominantly African Americans, life expectancy is 75. If you're taking the blue line or the orange line home into Northern Virginia, life expectancy is 80. If you're going to get on the red line and go out to Montgomery County, life expectancy is 81. So in this small geographic area, we've got a 9-year disparity in lifespan. Next slide. Here's a study that you may recognize, New Orleans. We see in New Orleans the same pattern. The green dots are in the center of the city and to the east. The blue dots are to the west. Next slide. So in fairness, here's my hometown, New York City. And so New York City is like a rainbow. You can see clear demarcations where one color ends and the other color begins, which illustrates the segregation of that city. And just to give you a little bit of an orientation to it, if I could just borrow this mouse for 1 second. This is Manhattan Island. And if you notice, there's a big white triangle in the middle of Manhattan Island, which is Central Park, because of course, nobody lives in Central Park, right? Oh, I'll tell you this.
That's debatable.
Oh, it's not debatable at all. I can tell you that. After college, I went back home to New York and I took a job as a social worker working with homeless people. So it was literally my job to call on people living in Central Park. I personally knew them. You know, I can assure you there are a lot of people living in Central Park, but of course they're not. So okay, next. So here I've drawn a circle around Brooklyn because if you've ever met anyone from Brooklyn, you know that from Brooklyn think that Brooklyn is the center of the universe. And of course, Brooklyn is the center of the universe because I am from Brooklyn and I'm one of those people. Next slide. And in the center of Brooklyn, that massive brain is a neighborhood called Brownsville, which is where I grew up. And Brownsville is 86,000 people living in about 1.2 square miles. Next slide, which is about double the population density of the rest of the city. And how do you get that many people into such a small area? You do it by building up. This is an aerial photograph of that Brownsville community. Next, that's the building I grew up in as a kid. Next, and that is the elementary school that I was supposed to go to, but didn't because the building was condemned right before I was supposed to start school, and it's been sitting there for the next 40 plus years. And if you look closely, you can see foliage growing on the top of the roof. Next. So I went there last In the introduction, I mentioned that I made a documentary film, and when we went back to the Inequities as part of that film, I wanted to try to get a picture of that. It didn't occur to me that it was the winter and the foliage was green. But this is the picture I took. If you look closely, you can see some of the branches coming out of the roof of that school. Next. Here's a bit of the food environment in Brownsville. Next. Let's move on to the next one. And this is just pictures from kids. I took that picture because they saw me with a camera and they wanted to take their picture. And if it was 40 years ago, I'd probably been one of those kids in that picture, so I took the picture. But if you look above their head, you see Crown's Fried Chicken, which is ubiquitous in northeastern cities, and Chinese takeout, which is the food environment in which they live, which is why this neighborhood has the lowest life expectancy of any community in New York. One of the reasons for that. Next. Here are some photos from Baltimore, a city that I lived in for many years. I'm going to see if I can do these slides. Wish me luck. I don't know what I'm doing on this pushing button right now. Is it having any effect? Something happened?
Yeah.
I hope I'm not like causing a real problem.
Those electrocutors.
So I'm more worried about it causing ambulances to go in the wrong direction. Oh, wait.
Oh, that's it.
Something's happening.
Oh.
Okay.
It's all or nothing.
There's got to be something. There's got to be something. Middle. No?
That's good.
It doesn't. All right, this is not. This is as good as I get. Right. Here's some photos from Baltimore, city I live in. This is these are corner stores, which are ubiquitous in Baltimore. Next, notice the signs selling cigarettes, lottery tickets, malt liquor, beer. Next, this is my favorite one. I took this photo. I'm actually standing in the parking lot of a funeral home that's owned by a friend of mine, while a funeral was taking place of a 22-year-old black man who died of a heart attack. 22-year-old black male died of an MI. Right? So it just seemed like the perfect photograph moment. So I'm taking a picture of this sign of the store, L&M's Liquor. They sell beer, wine, and medicine. And I did not Photoshop this. Next. I did not Photoshop that. This is literally what the sign says. And of course, this is truth in advertising because the medicine that they sell is the elixir for the ills of poverty. Malt liquor. Malt liquor is, of course, so I'm sure I'm the only one who knows what malt liquor is because I'm the only person that went to college here. There you go. So we have another honest man. So malt liquor is not beer. Malt liquor is about double the alcohol content of beer and is sold in much larger denominations. This is just a couple of examples from my private collection of malt liquors. Notice that they are all still sealed. And these are in my office. And I think Lucia and David attested the fact that these are actually in my office and still sealed. And in fact, I've had them for so long now, I'm not sure what would happen if I actually did open. I'm afraid to open the bottle. But anyway, I've added a bottle of Miller beer, traditional 12-ounce bottles to give you a sense of proportions. Malt liquor is typically sold in these 40-ounce bottles. And we have here the 64-ounce bottle of Old English, which is a 64-ounce bottle of glass, which is actually a pretty heavy thing, but it is ergonomically designed for easy one-hand consumption. It is absolute genius. It's evil genius, but it is absolute genius. So we did a study to look at where these products are sold within Baltimore City. We were able to get a list of the licenses and the types of stores that sold these products versus other products. And we arrayed them into the census tracts where the stores were located. We looked at where the licensed owners live, and we looked at the racial and social class, of the communities where these stores were located. The results are, the first result is that we did not find one example of a licensed or liquor license owner who lived in a census tract that had one of these stores. Now, let me be clear. It's not that they didn't live in the census tract with their store. we didn't find one example of an owner that lived in a census tract that had any of these stores. Okay. Next slide. But the primary finding was this: that the stores, that these products were sold almost exclusively in predominantly Black, low-income communities. Segregation facilitates differential exposure to health risks and differential availability of factors that are protective of health. And this is the driver that produces the disparities. And when we look at national data, national statistics, and we try to draw inferences from that, without accounting for the fact that people are living in very different risk environments, we make the mistake of assuming that the differences we see should be ascribed to some characteristic of the people rather than the communities they live in. It's almost like this: if we turned on Good Morning America, the weather report came on and it said, okay, today the average temperature for the United States will be 42 degrees. That is a calculable statistic. We can calculate that. But is it a meaningful statistic? Does it tell us here in New Orleans, do we need a jacket? Does it tell people in Seattle to need an umbrella? Right? This is what we rely on in most of the research that we do. These national statistics that don't account for the fact that there are differences in the risk environment, and then we conclude, oh, we adjusted for socioeconomic status in our multivariate model. Therefore, the residual race difference that's still there, it must be something about the people. There must be some gene, although I always challenge students, when you are told in your medical school class that there's some genetic difference, ask the professor to name the gene. I have not yet found anyone who can tell me the name of the gene that they isolated that shows that is producing these race differences. What's the gene that only exists in one race group? What's the name of it? And that gene would have to also be producing heart disease and cancer and stroke and HIV and homicide and schizophrenia and automobile accidents. How plausible is that? Next slide. Okay, next slide. So, oh, wait, I'm sorry, go back. I'll tell you another quick story. Do I have time?
Good time.
Oh, no, I don't have time. Jeez.
Go ahead.
Okay, I'm gonna speed talk. I'm a New Yorker, so this is my native dialect, speed talk. Next slide. So if we're gonna understand race disparity, we have to be able to account for the fact that people live in different race environments. One quick story is going to run me a little long, but I think it's important enough to tell you this. So I had a colleague back when I was at Harvard, a colleague of mine who asked me to review a paper that he just read to the journal. I won't get into what the paper was about because I don't really want to identify who the person is, but it was looking at a condition that was treated at the hospital, right? And he was arguing in his paper that there was a race disparity in quality of care that patients were receiving. So I'm reading this article for him, and I quickly surmised that, okay, wait a minute. From your description, the Black patients are mostly got into your study because they went to the emergency department, and then from the emergency department, they were admitted to the hospital, and then later enrolled into your study. The white patients disproportionately came through the ambulatory care center, and then were admitted to the hospital, and then enrolled into your study. I said, I don't think that this paper is documenting race disparities, because we would expect that patients that are coming through the emergency department are more likely in crisis when they arrive at the hospital. They may or may not be being followed by a physician in the community with Inequalities at Hopkins. Whereas the patients that came to the ambulatory care center had an appointment, which means they probably were not in crisis when they came. They had been referred there from a physician in the community that referred them. And so when they're discharged, they'll be discharged back to that physician's care. And we would expect that the continuity of their care is going to be better. So we should expect that the patients who came through ambulatory care are going to be better than the emergency room patients. And that's not necessarily effective. You know, there may be some racial disparities that produce who went to the emergency room and who went to the ambulatory care center. But you can't say that the hospital did not provide equal quality care on the basis of this study. And he said, oh, wow, that's a great observation. I thank you so much. Thank you profusely. And then submitted the article to the journal and where it is now published. And all I will say, I won't say the name of the journal, but I will say that it is a medical journal and it's published in New England. And so if we're going to study race disparities, what do we need? We need to find where patients have come through the same pathway, right? Where we're able to equalize as much as we possibly can. And that the real differentiator is simply how they're classified in terms of their race, which is a whole other question, whether the classification is accurate, but setting that aside for now. So we got this idea that what if we could identify communities in our country where you have racially integrated environments and no race difference in income or educational levels, would you still find the same disparity? Okay, next slide. So we did a study, we did an analysis of census tracts in the United States. There are 168,000 census tracts. We found 425 tracts nationwide that met this criteria that we established, which was at least 35% Black and 35% white living in the same census tract, not similar tracts, in the same tract. And income and education levels were equal between the two groups. Right, this is the criteria we used. Fortunately, 2 of those census tracts were in Baltimore and they were contiguous, so we decided to make that our study location. And we went into those 2 tracts, and we took portions of the protocol from National Health Interview Survey and Haynes, and the idea was to determine, do we find the same disparities when people are not dealing with where we don't have to deal with segregation. Next slide. So next slide. So just quickly, characteristics of these 2 census tracts: 51% Black, 44% white. Next. As you can see, the income levels were low but equal between the 2 groups. Next. Poverty levels were relatively high for that time, but again, pretty equal. Next. Educational status also very similar. So this is about as close as you're going to get to laboratory conditions in the natural current community. Next. Oh, distribution of gender is the same also. And I keep forgetting to add this, but blue is male and red is female. Next slide. Okay, so this is a 40-minute interview that we did mostly at their homes, and we have a sample size of 1,400, almost 1,500, which represents 42% of the adults living in those 2 census tracts. Next. Okay, next. So just quickly, how well do we represent the community? The blue bar is our study, the red bar is the census, where the census showed about those tracts. And just scroll through these next couple of slides. Just shows that we've got, I think, a pretty good representation of that community. Next. Okay, next. Okay, stop. Let's go back.
Sorry.
No, just stay there, stay there. So the way we did this analysis is we went into the literature. This is for hypertension. We went into the literature. We identified papers looking at race differences in hypertension between Blacks and whites that have already been published using Haynes. We then replicated the analysis in those papers in Haynes, and then we replicated that analysis again in our data set. And remember, we followed the Haynes protocol, so we measured things exactly as they did. So if you look at the Haynes, each of these models represent a different paper that we pulled from the literature. And as you can see across all 4 of these papers, the odds ratio is about 2. So about Black African Americans about double the odds of being hypertensive compared to whites. In our analysis, we find that that is not the case in any of them. We do still find a race disparity, but the disparities are significantly smaller. So what we can say is that at least some portion of that race disparity that we see is explainable by the fact that people are living under the same conditions in these 2 in our study. So when we teach medical students, public health students, nursing students in our classes, that African Americans have double the odds of being hypertensive compared to whites, and we say that without adding any context to that, we leave the students believing that there is something genetic or biological about that. Rather than, the fact is that when we're able to account for many of the social conditions, social factors, the Black population does not have double the odds of being hypertensive. They are quite different. So if nothing else, I would hope that as we go forward and we start talking about this in the classroom, that we no longer simply say African Americans have double the odds of hypertension compared to whites. If we're not going to complete that sentence, because there are social determinants that impact populations differentially, not because there are biological differences. I know I'm running long, but I can't help but tell the story. I went into for a physical one time, but a physician that I hadn't seen for years, right? And he had a resident that day, and the resident came in to see me first. The resident took my blood pressure and found that my blood pressure was normal. He looked at me with this puzzled look on his face. Then he went to the chart, and opened up on the computer, went to the chart, and saw I didn't have a diagnosis of hypertension. He was trying to say I was on meds or whatever. He took my blood pressure again. He was perplexed by the fact that a middle-aged black man did not have hypertension. And I'm looking at this guy saying, I have no clue who he's dealing, who I am, you know, and that I know exactly what's going on here. Anyway, because he had been taught that a black person, at that time I was like 40, 45-year-old black man has to have hypertension, because I don't know why he thinks that's the case, but it must be what he learned from medical school. So we conducted similar analysis to the hypertension analysis in other conditions. And here you see some of the results. So for diabetes, in the national sample, which I think was health in the survey, we find African Americans 61% greater odds of being diabetic. In our sample, we find no race differences in diabetes. This is published in the Journal of Internal Medicine. Obesity among women. In the national sample, African American women, 87% greater odds of being obese compared to white women. In our sample, no significant race difference in obesity among women. Hypertension, we've already discussed that. And then use of preventive health services. Here is interesting. We don't find significant effect in either, but it's interesting, I think, that at least the direction of the relationship is different. In the national sample, African Americans is a trend towards lower utilization of preventive health services, but in our community, what we did our study, we actually find the opposite trend. Okay, next. So this is the summary of that previous slide, so we can move on to the last point that I wanted to make, which is that we talk about race disparities, and that's what this lecture and this conference is about, but there are other disparities, and these other disparities produce the health disparities, and the health disparities produce the other disparities. And until we get out of the health sector and begin to communicate with our colleagues in other fields, we're not going to really understand the nature of our problem, our health disparity, and they're not going to understand the nature of theirs. And these other disparities are, next slide, health, wealth, education, and criminal justice. And by criminal justice, I mean aggressive policing and mass incarceration. So, next, we know that education is one of the best known predictors of health, and that educating at health, kids that have health issues are much less likely to be able to develop educational. Continue. That relationship, keep going. The relationship between education and criminal justice is well known, at very high rates of illiteracy in prison populations. People wind up in prison because they can't afford legal services that keep them out of prison. And the best way I can imagine populations of people from not developing wealth is for them to be in prison between the ages of 17 and 35, which is the age range where most of us develop the human capital necessary to create wealth. Next, the health-wealth relationship is very well known. Next, and we know that there are a lot of people who wind up in prison because of undiagnosed, untreated mental health conditions. And next, and that people come out of prison often more unhealthy than they were when they went into prison. Now, I don't think any of this is a shock to anyone in this room, but we don't often think this way. And we get focused on just health disparities and not consider that the health disparities is part and parcel of broader societal issues that are driving those disparities, and that we need to be communicating outside of our own sector. Last point. My apologies for taking so long. Next. Okay, I want to make this final point. So how many of you here are aware that there are more Black men in prison than in college? Don't be afraid. Next slide. Have any of you actually looked it up to see if that was true? We believe that without looking at the evidence. So I did pull the evidence. So in 2006, which is the first time I did this, there were 86,000 Black men in prison, 836,000 Black men in prison. That's 996,000 Black men in college. So there were actually more Black men in college than in prison. Next slide. So then I said, okay, wait a minute, the age range issue is important here. So the only way we can align the two databases, this data comes from U.S. Department of Education, U.S. Department of Justice, official data. The only way those data sets could be aligned was to look at the age range of 20 to 29. So in that year, 310,000 Black men in prison, 480,000 Black men in college. Okay, so now I said, so it's not true. In 2006, when I first did this, and then the next question was this ever a true statement? Next slide. So we went back as far as we could with good quality data from these two sources, and we could not find a single year where that statement was true. It is not true that there are more Black men in college, in prison than in college. It never was true. It was a lie the first time it was stated, and it is still a lie now. In fact, we look at how many more Black men there are in college than prison. It is a big lie. And this is only 4-year college. We did not include 2-year colleges. We did not include graduate or professional schools. This is only bachelor degree seeking college. So something that is so untrue here, almost 500,000 people. How is it as possible that we can believe such a thing? And what does this have to do with healthcare? If you can believe something like this, how does this impact the way that we deal with Black patients when they come to the hospital? If I say that there were more Asian women in prison than in college, how would you react? That would be utterly ludicrous. You would dismiss it immediately and assume that something was wrong with you to believe such a thing. Yet, so many of us, even President Obama, I heard once make that statement, that there are more Black men in prison than in college. So, if we get nothing else out of this talk, hopefully we get something more than just this out of the talk. At least, I'd like to enlist you in my one-man crusade to stop this horrible lie from being perpetrated about Black men. Thank you very much.
Thank you very much. It was a wonderful lecture. I just couldn't help wondering how you can be a dean without your blood pressure going up. You've got good faculty like Dr. Shi and Dr. Chen. So,
Yeah, there we
couple of questions.
no, that was before.
John.
Thank you. That was wonderful, actually. Great presentation. I have 2 questions. I'll pick the trivial one out first. I want to know, how good is that malt liquor?
Well, how about you come to my office? We'll open the bottle and we'll take this together.
But on a more serious note,
Probably a 25-year-old bottle.
That's
okay.
So you presented a lot of the problems. I was wondering if you had any suggestions on solutions to some of these problems, and where would you start? I mean, I understand the complexity here, so it's not something that can be resolved in a single clip here. But where would you start, and what's the highest priority for you in terms of addressing these issues?
Well, what my priority has been to try to re-educate the workforce. And some of the things I talked about, such as, is the science does not, it is not scientifically accurate to say African Americans have double the odds of being hypertensive compared to whites, unless you explain the rest of the story. Because there are the social conditions that place them at increased risk, and those risks is the reason that we want that disturbed. Not that there's some genetic thing, right? So that's one thing. We can correct that. This I mentioned it. The other thing about this Black patients should get diuretics and white should get calcium channel blocker. If you go to the all-head study, and I would love if any of you are interested to work on it. I've been wanting to write an editorial about this. When you look at the study that produced that finding, which is the all-head study, If you read what's written in the text, it says that. If you look at the tables and ignore the text and just read the data yourself, the data does not support that. The data shows that calcium channel blockers were the most effective intervention for African Americans, just as it was for whites. But for some reason, what's written in the text says something different, and then the Preventive Services Task Force took that finding, and now it's in their guidelines. Right? So we can start correcting things like that. So how about we just begin to, as we teach, as we train this next generation of healthcare workers, we be more careful and more nuanced in how we talk about these issues, so that they understand what are the drivers. That would be where I've been sort of trying to wage my doubt. I know I'm running long, so I'm going to try to get quick.
But this is something we have to think about, because we currently are teaching in the medical lectures in the second year. I guarantee you, the words that you said about, about IDL exactly is what's being taught. So we have to rethink this, and it can make impact on healthcare. Earlier, we were talking about, for example, the way that differences in underrepresented minorities are handled in regards to like kidney transplant. An equation, estimated glomerular filtration rate. All of a sudden, now that's been completely reevaluated, because the way it's considered makes impact on who gets the kidney.
Yeah.
Right.
So we can start there, looking internally, right? Just the way that we do business and the way that we try to use race. And I think it all stems from, I don't think there was any ill intent behind any of that. The idea was to try to use race as a biological concept. So when you're creating these standards, you're saying, okay, well, on average, African Americans are here and whites are there, therefore this is the standard for African Americans. That shouldn't be the way we approach it. We should approach it in terms of what, if the standard is this, we should try to raise everyone to that standard and not lower the standard because African Americans have these exposures that are impacting them. So I think rethinking some of these things, like that one, this is what I'm really glad to see that work is happening. Great ideas.
Other questions?
Thank you for this amazing talk, and it is also amazing how much error and misunderstanding, misconceptions exist on relation of race to health and so on. But one thing, just a small point caught my attention was the differences in the races compared to NHANES versus EDIC. There seem to be still residual differences.
Yes.
Did you analyze what they may be related to? What were the causes of? They seem to be significant. Right. They were much smaller, but they still look like they may be significant.
Sure. You mean for the hypertension analysis?
Yeah.
Right. Because the differences disappear from the other conditions. But for hypertension is the one case where we still do find disparity. And the best we were able to do was to reduce it by a third. Right. So 2/3 of the disparity is being driven by something else. And I don't know what that is yet. We did have one of the advantages we had in the field study over NHANES, that we do have a lot of psychosocial variables that NHANES doesn't have. If we had played around some of those variables, we were able to explain a bit more of the variance, but we still were not able to fully close that gap. So we don't know why that residual difference is still there in hypertension. Could there be a cultural dimension like diet and things like that? I think my suspicion is that it is something. It's either some behavioral factor, or it's it's sort of environmental exposure that we did measure in our study and didn't know the measure. Thank you very much again.
Thank you very much for that presentation. I think you had all of us on edge, and that's a good thing. And I'd like to ask a question which may lead to some follow-up discussion. We have been challenged by a leader of our healthcare system to develop a way of measuring disparities amongst the persons we serve so that we know we are making progress. What you have outlined is a very complex matrix to explain why certain things are different. And I would welcome the follow-on conversations for how can we more intentionally follow up on it, like Dr. Kerwin suggested. Given the matrix you presented, what do we do now? Partisan education, but we'd love to be able to move some of that into direct practice. So thank you for the presentation, the point that you made, making it sensitive to both what is real and where there are mythologies. And I hope we can have those following conversations.
Absolutely. I thank you for that. I really do hope that we can have the follow-on conversations. I don't have a quick, easy answer to your question right now, but I would love to engage in further dialogue and see if we can, try out some different solutions to see if we can identify those.
Thank you.
How much more time? I know I really. Yeah, we'll be fine with that.
Any questions on Zoom?
Yeah, let's go to the Zoom. Anyone in the chat box?
Complaints about the sound.
Oh,
You gotta fix that.
I have a question, just building off of Dr. Bob's question. Do you think that unmeasured variable to explain the difference could just be racism, exposure to racism, stress?
Well, maybe we had several measures of racism in the data set. And so I think it's probably that maybe there's some aspect of racism that we measure, or maybe our measure is not ideal. But of course, that was the first thing that we thought, okay, this is about racism. And I think it is. We do find correlations between responding to report of racism and hypertension, as many other studies have found. That's not a good finding. But it still didn't fully explain the remaining gap. Because remember, for someone to report in a survey that they were exposed to racism, they have to have perceived that there was some differential treatment, and then they have to attribute that treatment to racism. So it's possible that you could be subject to differential treatment, but not conclude it was because of your race. Right? So it's possible that that it's not an ideal measure. It's self-reported or self-perceived race, but not necessarily an actual measure of the exposure.
We have a positive comment in the chat that it's a great talk, but it only touches the surface.
Okay, well, I want to know what the next level below the surface is. We're still working on that, and hopefully others will join us in that work.
What do you think are solutions to these problems? What do you think? Could you suggest some solutions of how we should approach this issue?
You mean from a research standpoint or from
Both. Clinical practice as well as research.
from a research perspective? I think that's the easiest thing. I think we have to just be more thoughtful. But we don't approach race, we approach other things. You put race in a regression model and the R square is going to go up. I don't care what it is, what your dependent variable is, right? So your model fits going to improve and you're going to publish. But we just need to be more thoughtful before we drop race into the model. What do we mean by race? How are we measuring race? Is this the most appropriate measure? Give it the same scrutiny we give to everything else we do. I just don't think we do that from a research standpoint. In terms of how we address this in medical practice, I'm going to have to say the same thing. We have to kind of be more thoughtful about what we're doing. So this 42-year-old black male that doesn't have hypertension, his sort of underlying expectation was that, of course, you should have hypertension. By the way, it's only about 32% rate of hypertension in Maryland at that time where I was living. So the majority of black males in that age did not have hypertension, but somehow the training that he received led him to expect that the rate would be much higher, and that he was actually surprised that I was part of the 68% of black males in my age that didn't have hypertension. So I think it's being more thoughtful, and I think And I don't think it really requires a very sophisticated understanding. And maybe I'm overly optimistic here, but I think if we apply the same scrutiny to race that we apply to other variables that we use in our analysis, and we apply the same scrutiny to race that we do other things in our clinical practice, I think a lot of it would go away if we're just thoughtful about it. So before we say, well, for a Black patient, it should be necessary, for a white patient, that's that. Let's question that. Well, why is that? What is the science behind that? Is there really science behind it? Or is this something that we sort of been passing along through, experience-based rather than science-based practice? I think that's the key. We have to get to the point where we're operating based on science and not based on, I don't know, experiences of individuals who talk about their experience.
Yeah, well, great talk. I can give an example from my work, which is pulmonary function testing. And pulmonary function testing has long been said to vary by age, sex, height, and race. And African Americans are supposed to have pulmonary function variables that are 10 to 50% lower than age max, height, and sex match occasion. And that's actually in the formula that is used to interpret pulmonary function testing. And the end result is that African Americans have their severity of their disease underestimated because their normal values are brought down. And the correction for that, and when you correct for socioeconomic status and for some other things, some of that variability with race, whatever race is, goes away. And the answer to that is not as easy to implement as you think, but I think the answer to it is just to ignore race. In other words, to have pulmonary function tables that reflect the aggregate population as a whole, regardless of race. So we don't penalize or reward one race versus another in terms of whatever we determine as normal.
Well, you and I are probably 98% in agreement. The only thing is, I wouldn't want to lower the standards for whites. I would say I would go if the standard that we're holding for whites. I'm assuming that standard was developed based on scientific process, right? And that number is right. Now, that's an assumption. I don't know that that's correct. But if that is the case, what we should be saying is everyone should be at that standard. And we've got to get the Black patients to that standard also. And it may be a heavier lift to do it. But that's what we have to aspire to.
I agree. I'm just posing a practical implementation of this discussion in a particular field of medical practice.
But I think we agree. As a patient, I insist that when these types of issues come up, I insist that we help the standard for white patients.
You can't really hold them to the standard of white patients.
No,
It's better to hold them to the standard of the aggregate population as a whole, because you can't bring one up and not bring the other down. So you have to look at the aggregate. I think the easiest way is just to ignore race.
Well, I don't know how the standards was determined, right? So it's hard for me to respond to that. But I'm saying I'm assuming that the standard that's being used for whites came from some analysis, right? I'm assuming that was an appropriate analysis, and it came up with a number that is, where patients should be for optimal health. I wouldn't want to lower that number if that is how that number was developed, right? So I wouldn't want to lower that by aggregating everyone, because that's what the result would be. And that would not be good for whites. I'd rather say, if this is the standard, how do we get everyone to that standard? Because we want optimal health for everyone, right? That's the point I'm making. But I think ultimately it's a nuanced difference, but I think that you and I are basically right. That we shouldn't be having standards for different race groups. And as a patient, anytime I get a whiff of that, I respond as aggressively as possible. And if you're holding me to some black standard, no, you need to, I want optimal health, I don't want optimal black health. Because I know that for the optimal black health is not what we're able to produce in the United States now, and I want that level of care. And, you know, I see healthcare providers that do that. So I need a new primary care doctor, by the way, so maybe that's what it is. Okay, well, thank you all.
Thank you.